Welcome to today's Vermont Oxford Network Grand Rounds. Today's topic is Evidence to Practice, Oxygen in the NICU. I'm Danielle Arrett, the Osval Yemru Green and Gold Professor at the University of Vermont, and I serve as the Chief Medical Officer and Director of Global Health at Vermont Oxford Network. I'm joined by my dear colleague, Dr. Roger Soll, who is the H. Wallace Professor of Neonatology at the University of Vermont, Coordinating Editor of Cochrane Neonatal, and the Vermont Oxford Network's Director of the Institute of Evidence-Based Practice. We're pleased to have a guest discussant today, Dr. Wendy Timpson, who's an Associate Professor of Pediatrics at the University of Massachusetts and serves as the Clinical Chief of their Neonatology Division. Today, our sponsors are Vermont Oxford Network and our Institute of Evidence-Based Practice. The three of us have disclosures related to our leadership positions and no other relevant financial issues to disclose today. We will have a couple of different ways for all of the audience to participate in today's webinar. The first is to please use the chat feature. You can send your questions and comments to everyone, and we'll try to either address those right in the chat itself or bring some up into the discussion at the end of our time today. We'll also have several polls during today's session using the Poll Everywhere feature, and I'll review the three different ways that you can respond. The first is to use the web application. You can go to the website listed here or use the QR code. The second is if you have the Poll Everywhere app downloaded on a smartphone or device, you can use the username BT Oxford and join today's poll. And the third is if you have a cell phone, you can text to 22333, text BT Oxford to that number, and you can respond to the questions in either of these three methods. We apologize, answers in the chat are not able to be tabulated into the responses, so we please encourage you to use all three. So the first poll to kind of test out the Poll Everywhere feature, we're curious where the audience is joining from. Looks like we have over 460 logins today, and we know some of you have more than one person joining together. And so we're curious, what continent are you joining in from? Looks like we have mostly North Americans, but we have a number of different time zones and continents here today. No one in Australia or Antarctica, but it looks like we have all other continents represented. So welcome to everyone to today's session. And then the next poll that really helps us set the stage for today's topic is looking at the availability of having written guidelines. So the question is, do you, where you practice, have written guidelines that address oxygen saturation, specifically for very low birth weight infants? And the options are yes, no, or uncertain. And there's always some uncertainty, I think, when representing your whole unit. Looks like we have just over 80% of our respondents saying that they do have written guidelines focused on oxygen saturation. We'll get in, I think, to the content of what might be in those guidelines, but we have a sense of where we're starting from for standardized practice. So to dig a bit deeper, specifically into the content of those guidelines and the evidence behind it, I'd like to invite Dr. Roger Soll to give us an evidence review on oxygen in the NICU. Thank you, Roger.
Thanks, Danielle. Today, we're going to talk about evidence to practice, oxygen in the NICU. Previously, we've discussed the use of oxygen in the delivery room, but today we're going to focus on the evidence from randomized controlled trials and meta-analyses and discuss different approaches that teams around the world are using regarding the use of oxygen in critically ill and preterm infants admitted to the neonatal intensive care unit. The discovery of oxygen dates back to the 18th century, and many have been credited with the discovery, but certainly there's no one who has more credit in this discovery than Joseph Priestley, who reported the discovery of oxygen and described some of its extraordinary properties. This is an interesting experiment that Priestley did on photosynthesis, where he took a look at three different environments in growing a plant and having an animal and having the plant and animal together, and really is an interesting insight into photosynthesis. But it does remind us of a very simple fact, that in the middle, in the closed jar, where there is no oxygen, the animal cannot survive. Clearly, oxygen and survival have been linked from the very first description of oxygen itself. Oxygen was used in neonatal resuscitation from the late 18th century, from 1780 onwards. That's within 5 years of its first detection. It rapidly gained acceptance and infiltrated delivery rooms, and a century later, neonatal special care units. After over 200 years, the use of oxygen has only recently been questioned. The first person to seriously question it in the newborn was Ola Sogstedt, who demonstrated that hypoxanthine, a purine metabolite, accumulated during hypoxia, and that introducing oxygen in the aftermath of hypoxia could lead to an explosive generation of oxygen-free radicals. These studies represent the basis for understanding the hypoxia reoxygenation or ischemia reperfusion injury that has puzzled medicine far beyond neonatology. Our very promiscuous use of oxygen in the critically ill preterm infant probably dates to the 1940s, where Wilson and colleagues observed that periodic breathing in preterm infants was nearly eliminated with the use of 70% oxygen. Although Wilson cautioned against unrestricted use of oxygen, other investigators and the American Academy of Pediatrics advocated its liberal use. We were able to deliver very high concentrations of oxygen because of other changes in technology, particularly regarding the construction of isolettes, which went from basically drafty chicken coops to the modern day plexiglass isolettes that we use to this day. During this time, a unique and new disease was described. First described as retrolental fibroplasia, a grayish-white opaque membrane behind each crystalline lens, it is now better known as retinopathy of prematurity. Some of the first randomized controlled trials in what we might consider to be modern-day neonatology was a test of liberal use of oxygen versus more restricted use, which had very dramatic results that affect our practice to this day. In this trial, restricted use of oxygen led to less retinopathy of prematurity, then called active retrolental fibroplasia, and less severe disease, scarring disease, called cicatricial retrolental fibroplasia. Here, looking at the trials, we can see a dramatic decrease of about 50%, involving a tremendous decrease in the risk difference of 30% fewer infants with any signs of retinal disease. Interestingly, we see here, and we'll see in subsequent studies, the fact that in our attempts to restrict oxygen, we actually wind up with some small increase in death, a theme we'll get to, unfortunately, over and over. During this period, when we curtailed oxygen, we really saw the scarring, severe disease decrease dramatically, and it has stayed low in the past decades. That said, there is an increase in the incidence of any signs of retinopathy, mostly related to the fact that we are successfully resuscitating and supporting smaller and smaller and less mature infants. This concern is true in all settings, but particularly in low and middle income countries. But here's the counterbalance. A very interesting study from Mary Ellen Avery, the same woman who first described pulmonary surfactant, regarding mortality before and after introduction of a policy of oxygen restriction in infants weighing 1,000 to 1,499 grams. Here we see an increase in mortality by 16% after the introduction of more restricted use of oxygen. And so although we saw a diminution in the risk of scarring retinopathy, we see this very concerning increase in mortality. And this is what we are faced with as we take a look at the literature and our evidence on this subject, that we have serious competing risks, which will be viewed somewhat differently in each healthcare setting. Recent work done from Vermont Oxford Network, from Jeff Horbar and colleagues, shows that although there were tremendous decreases in retinopathy that were associated in the first part of this century, what we see now in the past 10 years is a flattening of the curve. Particularly in babies 24 weeks gestation, we see a baseline rate of retinopathy of 30%, approximately 1 in 3 24-weekers with evidence of severe retinopathy, but much less severe retinopathy in the somewhat more mature babies at 27 or 28 weeks gestation. So let's discuss how we currently think about the use of oxygen, and importantly, the use of oxygen monitoring and how we administer oxygen, and the impact on retinopathy of prematurity. The idea of monitoring really first came about with the use of blood gases, but that intermittent technology has long been cast to the wayside. Transcutaneous monitoring was perhaps the first continuous attempt at monitoring, and there's some interesting information we can glean from those studies. We'll also touch base on the policies and guidelines to decrease oxygen exposure, and importantly, the most recent multi-center trials. So let's discuss transcutaneous oxygen monitoring, a technology that is nowhere near in as great use as it was 20 to 30 years ago. It uses a Clark electrode to warm the skin and measure oxygen that diffuses into the tissue. The first use of this in the context of clinical trials comes from Bancalari and colleagues in 1987, where they used continuous transcutaneous oxygen monitoring and compared it to intermittent PaO2 monitoring in infants 500 to 1,300 grams. Although it is not a conventionally statistically significant result, there's a very large difference, a 10% difference in the risk of any retinopathy in infants who were monitored with continuous transcutaneous PO2 versus intermittent monitoring, a risk difference of around 11% that almost reaches statistical significance. What's interesting here is that we get a very similar signal to the original trials of restricted oxygen. We see decreases in retinopathy and scarring retinopathy, in this case in a smaller trial, not reaching statistical significance, but a concerning increase in death associated with our attempts to restrict and monitor oxygen more closely. The techniques of transcutaneous oxygen monitoring have been supplanted by the much easier and more widely available use of oxygen saturation monitoring, using a pulse oximeter, which measures the amount of oxygen carried in the bloodstream using infrared technology. What we know about saturation is that it is a good measure of our oxygen in a normal range, namely around 30% to 80% partial pressure of oxygen, but that the curve flattens out at over PaO2 of 80 and is not such a good measure when it comes to hyperoxia, which of course is our concern when it comes to retinopathy of prematurity. One study that got us all thinking was Wintin's survey of units in the United Kingdom, looking at oxygen saturation policies in those units and their results regarding ROP, cerebral palsy, and survival. They chose units that had some very different control groups in terms of their expected and goal saturations. O2 sats that were targeted between 70 and 90%, and O2 sats that units targeted between 88 and 98%. Tremendous differences were seen in retinopathy, but interestingly, they did not seem the concerning downstream effects that were seen in the previous randomized trials. No differences in cerebral palsy and no difference in survival, which got us all thinking more about what should our goals actually be. At the beginning of this century, Bill Silverman, who might be considered the father of modern neonatology, wrote about his concerns about our ignorance regarding the appropriate use of oxygen in these babies. He noted that in the 1970s, with the transcutaneous oxygen electrodes, they were replaced in the 1980s by pulse oximeters. But these technological advances, in his mind, provided a misleading sense of newfound accuracy. And here he's very critical. He says, to put it bluntly, there's never been a shred of convincing evidence to guide limits for the rational use of supplemental oxygen in the care of extremely preterm infants. He notes that for decades, the optimum range of oxygenation, and he notes how to balance four competing risks: mortality, retinopathy, chronic lung disease, and brain damage, that the optimum range remains unknown to this day. Well, Bill would be pleased to know that we have made some progress on this issue, though many questions still remain. In Lisa Askey's Cochrane review on the effects of targeting lower versus higher arterial oxygen saturations, we can see that real progress has been made in our understanding. Dr. Askey asks what the effects of targeting lower versus higher oxygen saturations are and how this is represented in different subgroups of infants. But let's take a look at the big picture. In this trial, Dr. Askey noted that there were 5 trials involving close to 5,000 infants. And that's an interesting situation because most of the time I'm talking about trials, we have many trials, more than 5, but with many fewer infants. So these are 5 large trials with a fair sample size. The reason this came about is that the investigators of these 5 trials had prospectively planned to combine their data as part of the Neonatal Oxygen Prospective Meta-Analysis Collaboration, NEOPROM. This is a very busy slide, but it talks about those 5 studies. Studies done in Australia, Boost 2, in the UK, in New Zealand, all part of the Boost Collaborative, the support trial done in the United States, and the COT trial done in Canada, some centers in the US, Argentina, Germany, Israel, and Finland. When we take a look at the patient population, they're very similar, mostly involving infants less than 28 weeks gestation. The intervention was identical: lower oxygen saturations with a range between 85 to 89%, and higher oxygen saturations with a range of 91 to 95%. Subtle differences were noted in how the trials were conducted. They had different nurse-to-patient ratios. They had somewhat different oximeters. In all cases, the oximeters were altered, so they read a standard mid-saturation, even if you were in the lower or higher saturation group. The primary outcome was death or major disability. And here we see from the Cochrane review the 5 studies that reported on death or major disability. And what we see is a very precise estimate that there is no great effect on this combined measure. The typical relative risk is 1.04. The confidence interval is narrow, from 0.98 to 1.10. And so we have a very precise estimate that, looking at the big picture, death or major disability, we don't see much of a difference in terms of how kids did managing the lower SAT goals versus the higher SAT goals. But like many combined outcomes, it makes sense to take a look at the components, and we discover some very interesting and concerning issues. There is a significant difference of death based on the saturation goals. There is an increased risk of death associated with the lower saturation goals. So we see a 1.16 relative risk with a significant confidence interval of 1.03 to 1.31. Expressed as a risk difference, we see a 3% increase in the risk of death in infants who are managed with the lower saturation goals, which could be as little as a 1% increase or as much as a 5% increase. A concerning number that suggests that it would take about 28 to 30 infants to be treated with a lower goal to lead to one more death. We don't see that reflected in major disability. Similar to the combined outcome, major disability has little impact based on the oxygen saturation goals. The typical relative risk is almost at the point of identity, 1.01, and the confidence interval is narrow, 0.93 to 1.09. When we look at other important clinical outcomes, we see that there is concern. Regarding severe retinopathy of prematurity, The trial shows a significant 28% decrease in the relative risk, 0.72, with a narrow confidence interval of 0.61 to 0.85. Discussed in terms of a risk difference, we see a 4% decrease in the risk of severe retinopathy of prematurity in infants who are managed in the lower saturation range. This suggests that for every 25 infants that we manage with lower saturation targets, we see one less case of severe retinopathy of prematurity. An unexpected finding were the results regarding necrotizing enterocolitis. This was reported by all 5 trials, and in the infants managed in the lower saturation range, there is an increase in the risk of necrotizing enterocolitis. The point estimate for the relative risk is 1.24, the confidence interval 1.05 to 1.47. This risk difference suggests a 2% increase in the risk of NEC in infants managed in the lower saturation ranges. Again, a number needed to harm in this case would be 50. For every 50 infants that we treat with a lower saturation target, we see one more case of necrotizing enterocolitis. So the authors summarize the fact that the lower SAT ranges, 85 to 89%, compared to higher SAT ranges, 91 to 95%, had no significant effect on their primary outcome, death or major disability. But the average risk of mortality was increased by about 28 per 1,000 infants. And in addition, there is an increased risk of NEC associated with management in the lower range. Schmidt and colleagues published an opinion piece related to this, who note that the trade-off between the potential benefits and risks of lower versus higher saturations may not be the same in each nursery. We use this illustration when we discussed oxygen in the delivery room, but the same is true. We don't want too much oxygen with the risks of retinopathy. We don't want too little oxygen with the risks of death. We want to get it just right. But just right may be different at each center. If your outcome of concern is the composite, death or major disability, it doesn't really matter which target you choose. But if death drives your decision-making, you would clearly choose a higher range to target. Whereas if retinopathy drives your decision, if your center has a very high rate of retinopathy, you might err towards the lower ranges. And the opposite is true with NEC, where the higher ranges might have some advantage. And so some thought has been given as to whether or not this should be customized for each NICU's perceived needs versus the fact that simply death is so important that we should all err towards the higher goals. So let's dig down a little deeper. These trials were very similar, and yet there are some results in each of the trials which are measurably different. For example, it's the support trial that had the greatest risk described of retinopathy associated with the higher targets. The COT trial did not. And interestingly, when we take a look at the curves of the lower saturation groups and the higher saturation groups, we can see that there was much less distinction in the support trial and much more distinction in the COT trial, suggesting greater success at the centers in the Canadian studies at maintaining oxygen saturation within their goals. So why is that? Well, for one thing, hitting our targets is much easier said than done. Here's the download from one of our patients at the NICU. And you can see that although our high alarm limits and low alarm limits are well thought out and fairly broad, that in fact, the infant saturation frequently is above our desired goal in terms of the high alarm limits for the majority of time. And there are a variety of factors that lead to this. When we did a simple audit of asking people to walk into their unit, look at their infants, preterm infants on respiratory support, and just tell us what's the spot saturation at that moment, we can see an interesting distribution that although most units have been successful in managing infants in the 94, 95, 96% saturation range, we can see that there's an interesting tail in the higher saturation range where they are inappropriately in a saturation range that we are concerned about the risks of retinopathy. And so there's an interesting distribution of where we fail and where we succeed on either end of this histogram. So what's missing from the discussion? Well, some of the human resource issues and some of the alarm issues are missing. Here's some very interesting work from David Sink and colleagues looking at nurse-patient ratio and the achievement of oxygen saturation goals in preterm infants. And what we see is that when the nurse-patient ratio is high, 1:3, that the infants spend more time in an undesirable saturation range of 98 to 100%, around 37% of the time. And as the nursing ratio improves, we see much better compliance with hitting our targets. So at a 1:2 nurse-to-patient ratio, we see that only 24% of the time are in the high undesirable range. And in fact, in a 1:1 ratio, we see that only 8% of the time are infants in the undesirable high saturation range. This tells us that there's a lot of issues around staffing, education, and human factors. So staff knowledge of unit policies and guidelines is critical. As we just saw, nurse-to-patient ratio is critical. Patient acuity is obviously critical, but one can imagine that in the last example from David Sink, the 1:1 nurse-to-patient ratios were because the infants were sicker, and yet they were managed more effectively. And patient age, but what our targets should be, probably also plays into our decision-making. Are we looking at the right phenomenon? There's an interesting literature that has evolved regarding intermittent hypoxemia in preterm infants. Not about the average time of where they're measured in their SAT, but intermittent hypoxemic events, which are common during early postnatal life, particularly in preterms. These events have been associated with multiple morbidities, including retinopathy, sleep-disordered breathing, developmental impairment, and mortality. The relationship between intermittent hypoxemia and poor outcomes may be dependent on the patterns, the frequency, the duration, and timing of these events. And we use many modalities to try to stop this in terms of treating apnea or treating other underlying respiratory illnesses. That said, we see that these events are particularly frequent, particularly in the 3rd to 5th postnatal weeks of life, where infants may have as many as 600 hypoxic events per week. When we take a look at how this relates to the studies looking at saturation targeting, we can see that in the support trial, a subset of the infants who were in the low SAT group had many more episodes of intermittent hypoxemia to be concerned about. So what about other innovative ways of monitoring our use of oxygen in critically ill infants? Well, one of the issues is, what's the target organ we're monitoring? And I think we would all agree, it's the brain. And so why not use monitoring of cerebral oximetry to see if we can improve outcomes? And in this very large study published in the New England Journal, these authors did a phase 3 multinational, pragmatic, open-label randomized trial examining whether treatment guided by cerebral oximetry for the first 72 hours after birth would result in better outcome than usual care. And they enrolled over 1,600 infants, 772 in the cerebral oximetry group, 807 in the usual care. And they applied the oximetry for the first 72 hours after birth. They didn't show much difference. There's no difference in death or severe brain injury at 36 weeks, the relative risk of 1.03 and a confidence interval of 0.90 to 1.18. And they showed no other serious adverse events, no differences in death, no difference in severe brain injury, no differences in death or BPD or death or late onset sepsis. And so, although a promising technology, little has been shown yet that makes a clinical difference in applying cerebral oximetry. What about better ways to adjust oxygen? If in fact nursing ratio mattered as much as David Sink's study showed, can't we do better than this lapse in our human abilities to adjust oxygen? And the answer is possibly. There are automated control of the fraction-inspired oxygen has a fair literature and needs to be considered about whether or not this needs greater use. Suvik Mitra and colleagues took a look at a meta-analysis of 15 studies which compared automated versus manual control of FiO2 in preterm infants on respiratory support. The available evidence consistently demonstrated a significant improvement in time spent within target saturation range. There were fewer episodes of severe hypoxemia, less need for manual FiO2 adjustment when using the automated oxygen control. However, none of the current studies look at the downstream clinical outcomes, such as chronic lung disease or retinopathy. And so, although very promising, still needs further trials. So, trials have shown us the appropriate range to maintain oxygen saturation, but maintaining that appropriate saturation is a complex task that includes oxygen targeting, alarm setting, staff response, and unit culture. And so I'll turn it back to you, Danielle, so we can discuss a little bit about what centers have done to try to achieve these goals.
Thank you so much, Roger. That was an amazing evidence review. I know you have provoked many questions for me, and I'm sure you have for our audience as well. And I'd like to encourage our participants to put some questions in the chat. We should have about 10 to 15 minutes at the end of our session today, which we hope to get to some of those. So please send us those questions. And as you all have heard, we like to focus on evidence to practice in our Vaughan Grand Rounds. So I'd like to invite Dr. Wendy Timpson to bring us to the bedside as we think about optimizing oxygen. Over to you, Wendy.
Thanks, Danielle. Thanks, Andy, for advancing the slide. I'm here today to tell you really about my passion project, which started on my very first shift as a pediatric resident in the NICU. It was a long shift, an old school 30-hour shift. I remember leaving feeling exhilarated, exhausted, and entirely overstimulated. I went home to take a nap. I laid down, but I couldn't fall asleep. The alarms were still ringing in my head. I can remember it as vividly as if it were yesterday. I wonder how many of you still hear those alarms after all this time working in the NICUs. I have to confess that I don't, at least not like I used to anyway. The years of exposure to these alarms have dulled my response, and I essentially have become part of the problem. So let's find out, next slide please, Andy, a little bit about the approach that you take in your own unit. We've got another poll everywhere question here. So per Danielle's previous instructions, either via text or the web link, please answer the question to tell us a little bit about your approach in your own unit. Do you have a one-size-fits-all, where every baby admitted to the unit has the same alarm settings, which is option A, some of you are choosing? Option B, do you have a standardized approach that includes patient-specific alarm settings that are driven by various clinical characteristics? Or option C, is there a lack of individualization, if you will, or lack of standardized individualization, meaning some providers adjust alarm settings based on patient characteristics while others don't? Or option D, which is unsure. So this is great. The polls are looking like there is a mix, but the vast majority of participants today work in a unit where there are some individualized patient factors that drive your alarm settings, which per Roger's summary of the review of the evidence in terms of oxygen saturation alarms is certainly very appropriate. Great. Andy, do you want to go on to the next poll question? Thank you. So in your unit, who's responsible for these alarms? Is it the nurses, respiratory therapists, providers, or do you take an approach where everybody is responsible for this? A fifth option, which we didn't include here, might be that it's unclear. No one knows who's responsible, which is often the case. It looks like most of you are responding that the nurses, 70%, although a nice strong third of us really feel that everybody engages in management of the alarms. Terrific. Next, Andy will queue up a video where I explore ways that we as a NICU community can tackle alarm burden and optimize oxygenation.
I'm going to share a little bit about how we tackle this problem from a quality perspective at my former institution, Beth Israel Deaconess Medical Center. Our first step was to understand the magnitude of the problem. We analyzed nearly 2.3 million alarms in a retrospective cohort of over 7,000 patients admitted to the NICU between February 2008 and June 2014. The 917 patients represented here are the subset of patients with a length of stay greater than 24 hours with at least 60 minutes of monitoring coverage that we could definitively link to our clinical record. This represents a whopping 177 alarms per patient day, or in other words, one alarm every 8 minutes per patient. That's a lot of alarm exposure, both for the staff and the families. Notably, most of our alarms, as broken down by type, were either advisory alarms, represented in yellow, or device alerts, represented in blue. These are alarms that give us important clinical information, but aren't necessarily those that need or require an emergent response, which really help to guide our QI work. While we recognize there may be a way to safely reduce our alarm burden by focusing on this nearly over 96%, we also need to call out the incredibly important critical alarms, which are, while less than 4%, still a lot of alarms, nearly 82,000 alarms in this data set. And they're alarms that represent individual patient clinical burden or warrant individual patient attention. So while implementing changes to address the 96%, we needed to always keep these in mind and remain diligent to avoid introducing a new safety problem to our unit. We studied a number of drivers behind this large alarm burden and found some interesting patterns, one of which I'll highlight here, which is the association between alarm rate and postmenstrual age in this population. So this graph depicts the alarm rate, or alarms per patient day, along the y-axis, and postmenstrual age by week along the x-axis, where we see this interesting U pattern in our population. Our youngest babies, less than 26 weeks, suffer the largest burden of alarms and also have a higher proportion of red or critical alarms, while the older population had more device alerts, or a larger proportion of their alarms were driven by device alerts, which wasn't entirely surprising, given that the majority was also driven by pulse oximetry alarms in our older babies who tend to be moving around, resulting in poor pleth or lost signal altogether. Again, we felt this information was really helpful to identify specific targets for our quality work wherein we could reduce alarm burden and without compromising safety of our patients. So I'd be remiss not to point out at this time that this massive exposure to alarms in our unit lead to desensitization and sensory overload, which has been shown in multiple studies to result in workflow disruptions leading to inefficiencies, distraction errors that can impact care, delayed response to alarms, and even missed alarms, which can drive morbidity and even mortality. It also stands to reason that some of these problems of inefficiency and ineffectiveness will also impact our oxygen management, leading to more time our babies will spend outside of their target saturation ranges. I'll move on to describe a specific QI approach that we took to addressing this burden at Beth Israel. Our key study aims were twofold. The first and priority was to reduce the audible alarm burden for all of our NICU patients by 20% during this time period. At the same time, we aimed to increase the proportion of time VLBW infants spent within their target saturation range. We identified 5 key drivers of our primary aim and tested some changes for each. The first and most important kind of overarching aim was focusing on overarching driver was the noise burden, or just the audible alarms that we're listening to. While all of the changes we tested and implemented had some impact on the audible burden, there were some specifically, including utilization of our remote control feature and rapid silencing, as well as pausing alarms during cares that really were kind of aimed at thinking about that audible burden that everybody's exposed to. The remote utilization was used in particular with feeding, when we knew that the nurses or another care provider was there and able to monitor the alarms, so silencing via remote was a safe intervention. We utilized rapid silencing of clinically irrelevant alarms with a lot of education around that process, and pausing or prophylactically preventing alarms, if you will, while we were hands-on at the bedside. At the top, you'll see 2 drivers, which were particularly targeted at specific patients who were known to be very labile in their oxygen saturation and required frequent titration. This led us to an intervention to incorporate alarm burden into the nursing assignment, knowing that these patients would need really kind of more hands-on care to address their alarm burden, as well as an intervention that we tested using histograms or oxygen saturation histograms to drive management of patients with the goal that that could also reduce their low and high oxygen alarms. At the bottom, you'll see two drivers that were focused on specific alarm types that we also worked on reducing. I won't get too deeply into it for the sake of time today, but I have to point out that our second aim was in some ways competing with our first aim. So obviously, if we were focused just on reducing alarm burden and weren't thinking about oxygenation, we would make moves to reduce our oxygen saturation alarm burden because those are the most frequent alarms in our unit. However, without implementing other ways to titrate oxygen delivery, this would most certainly compromise our ability to keep babies within their target range. So some of our drivers ended up essentially being balancing measures for others. We learned a lot about the challenges of implementing and sustaining these changes, and not all were successful, but here I'll show you a handful that were. This U chart depicts alarms per patient day over time during our study, with an initial rate of 166 alarms per patient day. The baseline was reduced to 152 alarms per patient day following our first PDSA, which was simply encouraging the use of alarm silencing, which also involved a lot of education, sharing out to our unit the volume of alarms that we have so that everyone gained a really solid understanding and appreciation for the problem at hand. Our second PDSA, which involves staff education and going back through our guideline to make sure we're including all staff members or all clinician types to respond to alarms and address alarm fatigue, was moderately successful. We did see some signal with our third PDSA, which was implementation of oxygen saturation histograms. I do want to call out the observed high point in August when our alarm burden increased by 50% over our baseline, or an astronomical point on our SPC chart, consistent with special cause. After digging into that data, we found that the vast majority of alarms were caused by just 2 patients in the unit, an actual astronomical 95,000 alarms by 2 babies at that period of time. This demonstrated to us how much individual patients can drive alarm burden in NICUs and how we really need to think about those patients when we're considering change ideas. For example, to us, it made sense to incorporate a process for alarm burden informed nursing assignment, which can really get at that individual variation. I wanted to share with you our 5th PDSA, which involves the yellow or advisory high heart rate limit. It was a highly effective way, or looking at this specific alarm type was a really effective way to reduce our alarm burden when we implemented it alongside some key safety measures. So at the outset, when looking at our alarms, we identified that a large proportion of our alarms were actually high heart rate alarms that were triggered between 200 beats per minute and 210, which is where our critical high alarm limit was originally set. We decided as a team, digging into it, that while this tachycardia is clinically relevant, it isn't necessarily something that needed to be emergently addressed, or in other words, run to respond to an alarm. So we looked at increasing our yellow or advisory alarm limit for tachycardia to 210. Along with that, though, we needed to do a lot of education and we needed to implement some safety measures to make sure that there wasn't something else going on with these patients that could be missed. So we looked at our policy and we changed the frequency of vital signs that would be triggered when patients were having mild tachycardia in this range. We also standardized the approach of alerting the entire multidisciplinary team when patients were having this type of tachycardia, and provided a lot of education, followed any patient safety events that were recorded around this, encouraged the use of the patient safety event reporting as we made this change, as well as did a number of case reviews and chart reviews. So along with all of those, it was a lot of work to implement all of those balancing measures, if you will, or the safety features. But in changing that high heart rate limit to 210, we were actually able to halve the rate of the tachycardia alarms for this patient population from 19 tachycardia alarms per patient day down to 10. So it was well worth it. So we learned some key lessons. I described the immense alarm burden, which was very helpful actually to document and to be able to share that out to our unit. It really helped to engage folks in the improvement work. We noted that patient factors are really driving the problem, and we needed to pay attention to them. As with much QI, there's a modest impact with education, and it's something that requires ongoing re-education to maintain and sustain change. And we noticed the big impact of hardwired changes and how looking at things like alarm limits and alarm settings can really impact the burden. So some practical interventions that you might want to consider. From this project, more than any other QI work that I've engaged in, I learned that the devil's in the details. I am not an engineer, but I learned more than I ever thought I would about how cardiorespiratory monitors work. And that deep understanding really led to the success. So I would say to know your limits and know your alarm limits. You can think about whether having narrow or wide alarm limits would be beneficial for your patient population in your unit across all different alarm types, whether it's heart rate alarms or oxygen saturation alarms. While narrow limits may increase your alarm burden, they may be important to help you achieve oxygen saturations in range, for example, whereas there is some evidence that wider alarm limits can reduce the burden, which may actually in turn allow your staff to be more responsive to the alarms that they hear. There's a lot of neat features of cardiorespiratory alarms, including averaging time of your oxygen saturations, latching alarms, so what alarms stay audible versus are released and stop after a given period of time, as well as alarm escalation patterns that all can be evaluated with your clinical engineering team, who it's important to engage in this work. So focus on the noise. I think this is very important because we know that reducing alarm burden or the audible burden, what people are exposed to audibly, is what is going to impact your patient safety. You can think about safe ways to utilize your silence features and your pause features on your alarms. And along with that, deploy balancing measures, of course, to make sure that you don't have any individual harm come to patients. I think the sharing the burden is very important because all of us are listening to these alarms, and the more you can engage a multidisciplinary staff, the more likely you are to be able to safely reduce the alarm burden in your unit. Finally, I'll just mention an article which actually was published right around the time that I was just starting to be engaged in this work and really hit home for me, and that is the family perspective. The title of the article is "Every 30 Seconds, Another Alarm is Going Off. Neonatal ICUs Can Take Their Toll on Parents." And isn't that true? A quote from the article from a family member: "An orchestra of alarms beeps incessantly. The nurses may grab your baby from you to get her to start breathing. It's just relentless." So if there wasn't another reason to pursue this work, I think the family perspective is it for me. While we all may have become a little bit immune to the alarms in our unit, I assure you that your families, the families you care for, that we care for, aren't. And that is great motivation in and of itself.
All right. Looks like we already have some responses. We have a poll already going, but I first wanted to thank Dr. Timpson for that wonderful overview of your work at the bedside and really bringing us to the bedside and thinking about the team aspect and what it really means to think about these alarm limits and saturation goals. So the alarm cloud we have put up here is if you could put in 1 to 2 words, and again, this is via Poll Everywhere. The website is at the top, or you can use your smartphone or the text messaging. 1 to 2 words describing what issues are critical to achieving oxygen saturation targets. Looks like we have a lot of words coming in, and staffing is giant and just right to the center, which I think based on the evidence you shared, Roger, with the nurse to patient ratio, and Wendy, your beautiful charts looking at really how much this plays a role. So I'm not surprised to see that at the middle. See if there are any other words that are popping out to either you, Roger, or Wendy.
Well, I think it's interesting to see the word individualized up there. And I'm not so sure that we fully explored all of those issues. And clearly some questions came out about, well, what about age? And what about criticality of the patient? And in the original poll, most people didn't say one size fits all. They just don't have a standard order. And I would argue that's appropriate, though I'm not sure I could tell you exactly which changes I would make at which ages. And I'm curious where you guys stand on that. But I think that's one of the unanswered questions, certainly not answered by the trials.
Yeah, very true. I'm practical. I'm an implementer. I like to think about how we actually get these things done, and I leave all of that important analysis to people like you, Roger and Danielle. But I think staffing. I was glad to see that rise to the top. I think that has very much impacted the work I've done, and thinking about an alarm-informed staffing model was very intriguing to our group, and it took a lot of iterating. And even when we felt like we kind of got it right in terms of identifying those patients where they're kind of, quote, high alarmers, or they really needed tighter management, and allowing that to inform the staffing on a shift-to-shift basis, it was so challenging, right? That's only one of many, many, many factors that drive staffing. So how to practically implement that, I think if folks have ideas about how to, try that and want to share it, I think all of us could learn from that for sure. And I agree with you about, the concept. I think a number of units, there were quite a few chats about changing, especially the saturation targets as babies get older postmenstrually, which physiologically may make sense when you're targeting, avoidance of various diseases and the impact of over or under oxygenation. But that is practically really hard too. I think I saw one chat, someone said, yes, but we may forget to do it when the baby crosses whatever threshold we've predetermined. So a lot of that is about standardizing your work. And so I guess I'm the person here on the call who will say, yes, we have to obviously kind of choose your target per, what Roger shared about what we know about how oxygenation can impact these babies' pathophysiology, but then really think about how are you going to actually do it? Because it doesn't matter if we choose the right target if you're not actually delivering it to the baby at the bedside.
Well said, Wendy. I think this is an area where we as a community still have a lot to learn, and I think an opportunity for us to share and learn from each other of what is working and really implementing the goals once they're agreed upon. A lot there. There was one additional question that came up, Wendy, that I was hoping to have your thoughts on. It was related to histogram use and also maybe to Roger as it relates to intermittent hypoxia. So I think there's a number of different ways that we're getting the information, like the pulse oximeters, but the histograms I know have been incorporated more into presentations on rounds. And once we have set the goal, what proportion of time are we staying within that goal? And any thoughts on if that's helping us reach those goals, or ways you've seen that worked well? And the timing piece, I think, was particularly in the question. Is looking at a 24-hour period of time appropriate, or should it be smaller slices? So any thoughts on those?
Yeah, maybe I'll start, Roger, and then I'll turf the target question to you, whether to pick a middle ground target. So in terms of histograms, this was one of the areas where I mentioned we had some successes and failures in our quality improvement project. This was one where I would say it was moderately successful, but hard to sustain. So there was variation in practice, and it was actually really hard for us to figure out how to have a standardized workflow that incorporated, looking at these histograms. We didn't know the answer to the question of what period of time should you look at. So what we did was as you mentioned, Danielle, we incorporated it into the rounding process. And we set some parameters, of a certain target gestational age or postmenstrual age we would round on these babies. They needed to be on oxygen support because otherwise it kind of didn't make sense and you were looking at data that was relevant. So we kind of tried to pick our population so we weren't asking folks to do work that wasn't helpful to them. And what we decided is that because we really don't know, we actually don't know what proportion of time a baby should be in a target range. We have some clues from the evidence, but because we didn't feel like we knew for sure, we actually just decided to put the histograms in front of the clinical team as they rounded and let them utilize it in the way they chose to on an individual patient by patient basis. And then we tried to measure, not very scientifically, honestly, but measure what the response was. Did the histograms change practice or not? And we got a kind of a mixed response in that, which is partly probably what led to the difficulty with sustainability, is that some folks found it useful, others didn't. The other thing is, again, I'll just say the devil's in the details here. So the period of time you look at, in your histogram is going to incorporate all of the combined information about what respiratory support the baby was on and how much oxygen the baby was exposed to during that period of time. So if there's a lot of variation in your respiratory support or oxygen delivery, you may need to look at a narrower time period. So you're trying to measure how does the baby respond to what we're giving them, obviously, right? So there's a ton to learn from it. I do not have all the answers. I would love to see more research looking at how to implement these, because I think that really can help us all.
Thanks, Wendy. I loved the question about the middle range. It has a certain human appeal, right? We showed there's a little harm here, that there's some benefit here. Let's cut the difference. But it doesn't work like that. Okay, for one thing, that implies that retinopathy and death are valued equally. Okay, and people would disagree with that. They will have different interpretations about the goals. It also implies that the middle range will show the same efficacy. We don't know if you would see the improved survival in the middle range. We don't know that in the middle range you may have not ablated the number of hypoxic episodes that infants experience. So as appealing as it may seem, you don't have the evidence for that separate hypothesis. And it, like I said, it ignores the trade-offs and how you value the trade-offs. I guess the other side of that would be, why not have a broad range? If this was proven, if you argue that death and disability is ultimately the outcome I'm looking at, why not set the range very broadly? Wendy, it might change your alarm burden. But we don't have any idea about the real efficacy of managing patients that way.
Thank you, Roger. The time always goes by so quickly. I think we might have time for at least one more question. And the question by Thomas Burke intrigued me. He, I think, commented rightly so on how heterogeneous the babies in these trials are, and the ability to then implement that at the bedside, as Wendy has showed. I was curious, Roger, if you have thoughts on, he's commenting on, is there an attempt to understand what an FiO2 ceiling might be, combined with kind of the floor pulse oximetry, or the targets that we are describing, thinking of the bigger picture. And hopefully, innovations are on the way that we will have more precise tools in our toolbox. But with what we have today at the bedside, any comments on that?
Well, I'm going to cheat and throw it back to Wendy. But at one point, based on Jeff Horbar's instigation, we all met together to see whether or not an individual baby should be tested in each range to see what, in fact, their management would be optimized looking at the histogram and meeting our goals. And so it really could be, and it's not absurd to think that we could do this, that it could be at the level of the individual baby and not just characteristics even of that baby. And again, we don't know if that will make the difference, but we certainly know that we get reports back in the unit all the time. This baby's not tolerating whatever your goals are, and we need to move or change or rethink the goals. But Wendy, I'd love to hear, you gave this the most thought of all of us. So love to hear your thoughts.
Yeah, there's a ton to look at there. I think, we called these babies the frequent alarmers. They were up and down, and you just, the nurses know these babies like the back of their hand. You go up by 1 on their FiO2, and all of a sudden they're digging high. And, it's just, they're so demanding. So I think those patients certainly are an obvious target for individualization. And I think knowing what we do know about, I think we've got a lot of solid evidence about, broad, big populations that are pointing us in directions for various, what you can do to avoid various types of pathophysiology, morbidity, mortality, NEC, ROP. You can look at the rates of those in your unit and then look at those individual babies. And I do think it's very reasonable to consider that approach, individualizing for a baby. Someone had chatted in really quickly, and then I could go on forever about this, but someone chatted in, what about the noise and the impact that the baby, on the individual baby, the noise? It stands to reason. We know that there's safe decibel limits, and we know that many of our alarms, the critical ones, certainly go over those. It stands to reason that some babies are going to react to the actual sound of the alarm, and that's going to impact who they are, their physiologic state at the moment. So I think all very reasonable thoughts. I have more questions than answers. But yeah, I think individualization is certainly a really interesting thing to pursue.
Thank you, Wendy. And time is short. I think I'm still left with questions as well, but I think, that some take home points of look at the data that you have for your unit, think about that practically, ensure that you're doing this as a full team, and what is practical for your unit, and be aware as the evidence continues to evolve of making sure we're up to speed with what the current evidence is showing us. So thank you both, Dr. Soll and Dr. Timpson, for sharing with us today. For everyone who has joined in, you can receive 1 hour of continuing education credit. You can use the QR code or the website here. You'll receive a follow-up email which has it, and you can do that within 30 days to get your 1 hour of continuing education credit. And we hope to see you again in November as we focus on evidence to practice in the NICU environment, which is, I'm sure we'll have just as many questions as today, and will be a wonderful session together. For teams that are excited to learn more, we welcome you to learn more about our current NICU collaborative on All Care is Brain Care. So please reach out if you have more questions on that. Thank you very much for joining us, and we'll see you in November.